All right, good morning, everybody. Nice to see you all. What a great event. I said to Lisa Ellinger, who is kind of running the show, what if you threw a party and everybody came? So thanks for being part of the great crowd that is here for this inaugural La Follette Forum. So I'm Karen Timberlake, and I'll be serving as your moderator today, and really am delighted to have such a fantastic panel. Let me tell you just a little bit about our structure today, and then I will introduce our panel. You'll find more extensive biographies, which deserve a good read about all of our panelists in your booklet. And then I have just an opening framing comment or two, and then what we're going to do, I guess this is where I segue into the structure. So I'll have an opening framing comment or two. Then what we're going to do is have each of our panelists speak for just a couple of minutes about how they see this broad topic of consumerism in healthcare and kind of what's working and what's not working, and what we would like to be having an interesting discussion with all of you about. I, of course, then have a series of questions. We're going to hope for some good dialogue amongst our panelists. And then at the end, we're going to reserve about 15 minutes for questions from the audience. Victor, where'd Victor go? There's Victor. Victor, our La Follette student guide for the morning, will have a microphone, and he will run out to you in the hallway, or in the hall here in the aisle, and make sure that you can ask your question in a way that everybody can hear. So with that, let me say just a couple of quick words about who's on our panel. So immediately to my right is Justin Sydnor, who is the Leslie P. Schultz Professor in Risk Management and Insurance at the Wisconsin School of Business, as you'll see as you find his bio. Among his research and interests that are relevant to today's discussion, he is the director of the Behavioral Research Insights Through Experiments Lab, and he's also the associate director of the UW-Madison Center for Financial Security. So thank you, Justin, for being with us. Next to Justin is David Pate, who is chair and associate professor of social work at the University of Wisconsin-Milwaukee. So we're very glad to have David here from Milwaukee. David is also an affiliate of the Institute for Research on Poverty here on the Madison campus, and also an affiliate of the Collaborative Center for Health Equity at the UW-Madison School of Medicine and Public Health. His research focuses in particular on low-income African-American men, fatherhood, child support, and a variety of really interesting topics around consumer engagement. So happy to have David. Next to David is Eileen Mallow, who is the director of the Office of Strategic Health Policy at the Wisconsin Department of Employee Trust Funds. If you are a state or a university employee or an employee of some local governments, Eileen purchases health insurance on your behalf, and I'm sure she'll say this, but I think it's roughly $1.5 billion of healthcare purchasing done by Eileen Mallow and her not very numerous team. So Eileen, as you'll see, has a distinguished career in state government, was the former deputy commissioner of insurance, and has been at the Department of Employee Trust Funds for a number of years since. And then next to Eileen is Michele Erikson, who is the executive director of Wisconsin Literacy Incorporated. Michele herself has been working in adult literacy for many, many years, and in health literacy for really about the last 15 years or so. And Wisconsin Health Literacy, which is a separate division of Wisconsin Literacy, was launched under her leadership, and I know she'll say more about that. So we are here, before I turn it over to Justin, who's going to give us our first kind of opening remarks, we are here really to talk about this question of how do we better engage all of us and really everyone in the country as active consumers in making good choices, not only about our health care utilization and our health insurance, but also our health and our overall well-being. And I really do want to make sure that as our discussion goes along, we don't focus so narrowly only on what's wrong with high deductible health plans and what are we going to do about it, although that is a part of what we will talk about. But as we know, and as other panels throughout the day are going to talk about, our health and our well-being being are influenced by so many other factors, and this question of consumer engagement and efficacy and agency for all of us in decision making is really something that deserves a focus in this conversation as well as in some other rooms. I thought Drew Altman did a nice job of framing up kind of our question today, which is how is it that we've made this transition from, as he said, better coverage to crappier coverage, that technical term that you all learned this morning, and his point about the fact that we as a country really have not grappled yet or come to successful resolution on how much of what kind of cost sharing do we really need to drive the kind of behavior that we're all looking for. So our panelists have a lot of thoughts about those and many other topics. And so as noted, with no further ado, I'll turn it over to Justin to just kick us off with some opening remarks and what's interesting and important about this topic. How should we be thinking about it?
Great. So I'll give the kind of token economist on the panel perspective on this. And in some ways, I think, and we may talk about this a little bit more later, economists have some culpability in the sort of move towards more cost sharing and high deductible health plans over time. It was sort of, 20 years ago, sort of the big idea in health economics about sort of switching towards more cost sharing and having people have more skin in the game and other things. I think as we talk about that topic, it's helpful maybe to have a distinction between two issues that come up when we talk about this topic of high deductibles and rising deductibles. And the one that I think echoes what Drew Altman was talking about this morning is how the share of healthcare costs people are responsible for themselves, and how the overall cost of healthcare is hitting the bottom line for consumers in the country and for households in the country. And I think that's the main thing people tend to think about when they think about high deductible plans, that the costs are really high relative to incomes. But I think from an economist sort of policy analysis point of view, that is sort of a side piece of a much larger question of how we deal with having people in the country have enough money to handle all the costs they need, education and healthcare and a range of other things. And so it's part of a bigger question about redistribution and wages and a lot of things that aren't solely about healthcare. The other piece, and I think the piece that might be a little bit more productive for our conversation today, is about the role of this move towards cost sharing in its role in trying to help contain the cost of healthcare. So one of the reasons economists were excited about it was not to sort of push costs onto households, but instead the theory that having people have costs that they would bear would give them some cost sensitivity and would put some much needed cost containment into a system where we've been having a lot of problems containing healthcare cost growth over time. And that's a piece I thought I would talk a little bit more about on today's panel and sort of what evidence we've seen in regards to that. So, I think there it's also helpful to recognize that you can talk about that piece without necessarily mandating that people are facing more overall costs. And we see this, for instance, with many of our employers. As they transition people to plans with higher deductibles, they're also giving people contributions into health savings accounts. The theory there is, in theory, you might be able to have as much support from your employer for your healthcare costs, but you might have some levers that you're willing to pull to be cost sensitive. What the evidence has shown as that transition has happened, though, is that people are quite cost sensitive. As we've seen this rise to high deductible plans, people do spend less in healthcare. They do respond to those costs. But most of the evidence mounting suggests they're doing so in very blunt ways that suggest that they struggle to actually make what we might think of as informed, cost-sensitive decisions here. And so it's looking like a very blunt instrument that's problematic for a lot of people. And we don't have the systems in place to have the sort of cost transparency. It's not entirely clear that this is going to be a very effective way of getting that cost sensitivity. So I think the interesting challenge and kind of question going forward is the underlying economic need to find some ways of creating cost sensitivity within the healthcare system hasn't disappeared. And to the extent that this movement isn't serving as a productive way of meeting that challenge, how can it be improved and what else can we do going forward?
Great. Thank you, Justin. David, I'm actually going to have you back cleanup. So we're going to go to Eileen and then Michele, and then we'll come back to you.
Right.
So Eileen.
Good morning, everybody. As Karen said, I'm the Director of the Office of Strategic Health Policy. We do the contracting for health insurance for state employees. We have 240,000 people roughly in our group, meaning that we're probably the second largest purchaser of health insurance in the state of Wisconsin. We do what's called uniform benefits. We write one contract. We write the contract, so we tell the health insurers what we want them to do. It does help us manage costs in some ways. But when you have that many people, we have 9 contracts plus a Medicare Advantage contract that cover the people of the state of Wisconsin, and you have the distribution across counties. We go through a process every year where we qualify every health plan by county in which they're allowed to offer to make sure that they have adequate coverage of providers in that county. We also offer an HDHP plan, so there's incredible variation in what we offer to employees. And ultimately, this is a very individualized decision for most people and their families. You may have a sick person in your family, you may have a doctor or a health system that you're more comfortable with. So part of what we want to do is help people make the right decision up front. And that, I think, is an important part of consumerism. If you start and you can't, for example, fund your HDHP, and I'm not here to bash HDHPs, because if you go through the system that, or the educational materials we have, most state employees would be better off in an HDHP. But if you don't understand as a consumer what you're buying when you're in an HDHP, if you can't afford to fund the deductible or find a way to get enough money to fund the deductible with your HSA, you're going to be in trouble and you're going to end up with unexpected medical care. Mm-hmm. So a big part of what we're working on right now is to help our members understand what they're buying, make sure that they get the providers that they need in their network, to understand what it means to have, for example, a specialty drug, which has in our plan some fairly high cost sharing with our members, and just help people better understand what they're purchasing up front, help them make better decisions when they're not stressed with an acute healthcare episode, and get them going in the right direction from the word go. And I think that there's a lot that we can still do. If you are a state employee, you've probably bumped into Alex, which is our online tool to help people better judge and make decisions about what healthcare they're purchasing or what the basic structure is of their healthcare. That will, as I said, recommend for most state employees that the HDHP plan is a better deal for them. It's still been a leap of faith for many of our members to do that. And we have, Douglas is going to correct me if I'm wrong because I have several staff in the room, 17,000 people on an HDHP out of 240,000. That's not that many. Last year, when we changed from 2019 to 2020, something close to 10% of people backed out of the HDHP and went back into the more traditional health insurance plan. We don't know yet why that happened. That's certainly something for us to look at. The other thing I would do is echo what Justin said, which is, when people are in an HDHP, does that actually change their purchasing decisions? Our initial analysis would say no. We found that emergency room usage, for example, is no different for people who are in an HDHP plan versus a traditional health insurance plan. So we have a lot of work to do yet to understand that. We're getting better and better data. We're working with Justin and some of his students to help us understand better what our data is. So going forward, we have a lot of work to do, I think, to help consumers better manage how they spend their health insurance dollars.
Great. Thanks, Eileen. Michele.
Okay, as a director of Wisconsin Literacy Inc. and Wisconsin Health Literacy, when I first got into doing the health literacy work, I really thought that this was an issue, given my literacy background, that we needed to address to help people that struggled with literacy, had reading challenges, kind of understand our healthcare system. I soon learned that was not the case, and that really what we're doing in health literacy is something that addresses the needs of all of us, no matter what our level of education was or is. 88% of the U.S. population is challenged by our healthcare system, according to the National Assessment of Adult Literacy. And I think that any other industry would truly struggle to stay in business if only 12% of their customer base really understood their product, knew how to find it, could access it in a timely manner, and could use it to improve their quality of life. And yet in America, we are spending $3.9 trillion a year on healthcare. That makes us about the fourth largest economy in the world, right ahead of Germany, who spends about $3.8 trillion for their gross domestic product. And I don't think that that investment represents some of the best health outcomes in compared to other countries in the world. So Wisconsin Literacy is a coalition of about 70 literacy agencies, and we are focused on improving lives and strengthening literacy statewide. And our health literacy division's vision is that all people in Wisconsin will have will be able to access and understand health information and services. We believe that clear communication between those who are receiving health information and those who are giving health information really helps people first find that information, understand health concepts, and then be able to make informed decisions about the care that they have. And that 88%, I just kind of wanted to do a quick little analysis, since this is a health policy forum, on really where people are with being challenged by our healthcare system. So I'd like to ask you just 6 quick questions, and I'd like to ask you if you would, I'm sorry the educator's coming out of me, but raise your hand and keep it raised if you answer yes to any of these 6 questions. If you would keep your hand raised throughout the whole time to see where we are at the end. So again, if you can answer yes to any of these questions, would you raise your hand if you have ever walked away from a healthcare visit unsure of all that you needed to do to feel better? Could you raise your hand if you have ever heard words used to describe your own health condition, but you had no idea what they really meant? Have you ever been uncertain of a multifaceted medication regimen for you or your family member? Keep your hands raised if you've had them raised so far. Ever been uncertain of the directions for use on a prescription medication label? Okay. Have you ever been uncertain how your health insurance benefits, copays, deductibles will work on an actual doctor visit or a hospital visit or an ER visit? There we go.
That's right.
Okay, and if this doesn't get the rest of you, I don't know. Have you ever walked into a healthcare visit having no idea what the actual cost of services was? And opened your checkbook anyway, right? Okay. And we are, I'm thinking, an audience that is pretty much above average when it comes to health care engagement and understanding. So there's our 88% challenged by the healthcare system. So at Wisconsin Health Literacy, we are really working to provide programming in communities throughout the state. We also work beyond the state borders to help reduce that gap between how information is communicated and the capacity of all of us, not just folks who are challenged with literacy, but for all of us really to access, find it, and understand it. Our work includes kind of culturally appropriate approaches in taking health information to a level where everybody can understand it, and then sharing that information in trusted community settings where people live and work and play. We also have services for healthcare systems. We work with providers, we work with public health and health systems to help them learn strategies to communicate in plain language in ways that everyone can understand. And I was happy to work with ETF. They really invested in a lot of training for their employees to deliver their benefits and information to their members in a health literate way. We have a National Health Literacy Summit every other year, and we host our first inaugural Health Insurance Literacy Summit. Most of you raised your hand on that insurance question. Will be August 6th, so we hope you can put that on your calendar. We are right now training librarians to help them with their patrons be able to access and understand trusted health information online. We do a lot of community workshops around health-literate approaches to understanding opioids, pain medicines, just medicines in general for refugees and immigrants. Right. Also, we're doing workshops to help train caregivers around understanding how to use health-literate approaches with Alzheimer's and early dementia patients. So this health literacy concept applies just in many facets of health to understanding.
Great. Thanks, Michelle. David, give us your opening thoughts on our wide range of topics here.
Trying to do. Again, I want to thank you, Karen, for inviting me, and also the La Follette School of Public Policy for inviting me. I really appreciate the opportunity. I live in Madison, but I commute to Milwaukee. So I'm happy to be home for a change.
There you
I'm
go.
going to Milwaukee today. I'll
There
be
you
there
go.
tomorrow. Oh, no, I'll be there later today. What am I talking about? After this meeting. My work has been primarily focused on black males and their interaction with the child support system. And in looking at the child support system, one of the things that I learned early on was that the men who had children out of wedlock and they had their child delivered using Medicaid birthing costs were required to pay that back to the state. And that's how I first learned. That's how I looked at that's how my first interaction with cost sharing came about, where you had really no choice. And that cost sharing could be anywhere from $1,200 to $70,000 to $80,000, depending on the birth of your child, whether it was a normal birth or the child had to be in a neonatal center. We're the only state in the country that requires that people pay back their Medicaid costs if their mother uses the birthing costs in the state. It's an option that was implemented under President Clinton in the child support legislation under Perot, and Wisconsin took advantage of that, and every 72 counties in this state has taken advantage of that. And that's how I learned first about cost sharing, how poor families who make less than $10,000 a year, some who make more than that, are paying back the state to reimburse them for the use of an entitlement called social welfare, an entitlement under the social welfare policy. My work in Milwaukee is really very interesting to me because when I first started doing it in 1997, the one thing I thought was very interesting is that now Milwaukee has declared racism as a public health crisis. They did that last May. It's been something that I've been working with them on, thinking about how do we look at racism as a public health crisis, and what are they trying to do to implement the practices in the state, in the city, to be able to provide everyone equal access to health care. That's how they're thinking of really reducing racism or practices of racism in the city, or structural racism as they will call it, which is basically a lack of access to services available to everyone. One of the things that I've tried to do in all of my work is examine how does poor education, poor employment, and poor access to housing or lack of housing involves how it affects people's ability to live a healthy and stable life. And again, I use healthcare in a very broad sense. As a social work chair and professor, I look at mental health services in addition to people's physical health, and how are they able to maintain that. And that's been a big issue for us in our school, but also in the work that we've done. 3 of the projects I've tried to do in the last 5 years in particular that looks at healthcare is my examination of the WIC program, a program particularly in Kenosha, and looking at whether or not men who are very engaged with the mothers of their children, how does a WIC site provide an opportunity for men to be engaged in the services? And I'll talk about that later. As well as some of the work I've been doing more recently is looking at the issues of infant mortality, and how do you engage men in infant mortality services through a marketing campaign and the use of social media, as well as I'm now looking at the issue of incarcerated men, because a story I learned in 1998 that was very telling to me was that I learned one man were being incarcerated for non-payment of child support as part of my findings as a researcher. And then I've talked to many men over the years and asked them, what's going on with when you're in jail, or when they come out of jail. Some of them go back for a variety of reasons. And one thing I learned that people often are surprised by, that many of the men will plan purposely to go to jail when it gets cold, or when they can't get their health care benefits taken care of, because they will get guaranteed health care in the incarcerated system, the criminal legal system. And I think that's just unfortunate that the only way people can get access to health care is through a system where they have to do something that now is a stain on their record, their employment record, of course, and many of the black men that I've talked to, once they have that stain or that mark on their record, are no longer able to get any viable employment, or they're able to get some employment that's usually through a temp agency, which are very popular in Milwaukee, which I think takes advantage of a lot of men's human resources, and they get the benefit of the wages that these men bring in the other services. So I've been looking at this issue in a very broad sense of how does it affect their mental health as well as their own personal health. But also I've been able to, with colleagues, explore this around the issue of trauma and what does trauma really mean when you're looking at the social determinants of health that people are dealing with on a daily basis. And we're asking them to be able to fulfill the requirements of being a citizen of the United States. So I look forward to further questions and comments, and that's what I'm doing right now.
Great. Thank you, David. All right, thanks everyone. Great opening comments. So I want to loop us back to the top, if I could. So Justin, you started us off by talking about the fact that the move toward consumerism in healthcare, whether that's more consumer-directed choice of health benefits or certainly more consumer engagement in the choice of healthcare services, was in part an effort to inject cost sensitivity into the overall healthcare system. We certainly heard this morning about the fact that, cost is among the challenges we haven't solved. David just talked very eloquently about the impacts of that lack of investment in all the things across society that we need to be investing in. So, Justin, can you talk to us a little bit about, is there any evidence that we're doing any of this right in terms of engaging consumers in health insurance and healthcare in ways that is creating that cost sensitivity and causing kind of the right decisions to be made, in quotes? If not, where would you recommend that we start to focus some of that attention?
Sure. So it's a big one, but I guess maybe I'll start with the pieces that maybe aren't working so well, or maybe elaborate a little on what I said is the evidence we have emerging. So, probably the best evidence we have about the extent to which trying to create a system where we'll have consumers who have their own skin in the game and potentially have tools to look up prices and are going to comparison shop and think about the prices of things. We have actually a pretty good test of as close to the ideal version of that as we can have that's been published in the literature. So there was an academic study that studied a big technologically savvy workforce at a major Fortune 500 company where the employer shifted everybody from a very generous standard sort of plan with very low deductibles into one with a high deductible, but also funded very generously into a health savings account for the people. So in theory, they shouldn't have been any worse off in terms of financial burden, but they should have had some reason to think about the cost of each service they were getting. And that was sort of, the economist's dream maybe 15, 20 years ago of how this might work. This was also a very, a company that was very technologically savvy. The workforce was highly educated, and they had access to some price transparency sort of tools that were developed that would allow you to, for instance, look up what's the cost of getting an MRI in, hospital A versus hospital B. And what the analysis of that big shift at that employer found was that after that introduction of the high deductible version, there was about a 12% reduction in healthcare spending at that company. But it was very blunt and across the board. So at that company, it happened, in a whole bunch of ways. So people did pull back on ER spending there, and I think that's partly because the entire company was shifted over. But they also pulled back, you might have been hoping that it would be targeted largely at questionable imaging studies for low back pain or something else that we might think is sort of a place where we'd like people to be cost sensitive. But it was really across the board. People who needed checkups for diabetes, for instance, were not getting those checkups. And this was, it sort of suggests that people were quite cost sensitive, but not in a way that allowed informed decisions. And I think the mounting evidence is that the system is not set up well to let people think in terms of cost terms. It's also not necessarily an ideal time to be doing that. When you need care, what you're looking for from your interaction with the healthcare system and your doctors is not a discussion of sort of a negotiation of the lowest cost way to get things. So I think a lot of the mounting evidence is suggesting that just sort of this fairly blunt version of transferring costs to people, even if you're doing the version where you support and try to reduce the overall burden, that it will have effects on what people do, but not in a way that really empowers them or leaves them feeling empowered, which might have been the ideal. So to me, I think as we think about this type of thing going forward, if we're looking for sort of positive nuggets, I think where I've seen, and we haven't had a lot of good studies of this, systematic analysis, but there's at least some nice anecdotes emerging that I'm aware of, and some others on the panel, Eileen may know more about some of these efforts, that in some places you're starting to see for instance, employers who are partnering and hiring their own on-site healthcare workers, sort of nurses or general practitioners who can help people navigate the system in an informed way. And can both sort of be thinking about how to help people get good access to care they need, but also helping them be cost sensitive. And the real challenge there is finding a way within the system to have that be in a place where all the incentives are aligned, where you can have someone who can help you navigate the system who also cares about trying to hold down the costs. And that's a tricky thing to do, but I think we're starting to see a few nuggets of this sort of, like the on-site nurse or doctor who can't provide everything but can help you navigate the system. And so I think there may be some interesting things in that direction going forward.
Great, thanks. Eileen, do you want to pick up on that just from the perspective of ETF? So you talked a little bit about your efforts to move into more of a consumer-directed plan design. Consumers are now voting with their feet, but this is not the only thing you're doing, I'm sure, to engage people in their health and healthcare. So give us the bigger picture.
So we have a public board that we're answerable to. That board has asked us to look at on-site clinics and whether or not that's feasible or something that would be cost-effective. So we'll probably go to the board with at least preliminary work on that in May. And I wrote down very carefully your note about how the on-site clinic staff might help people be better navigators of the system. I think from our perspective, the on-site clinic is a challenge for us. Most state employees, as you would guess, are concentrated in Dane County, and it's pretty hard to walk more than 2 blocks in this city and not run into some kind of a healthcare facility. So I'm not sure that it's workable here. There might be other places where it's workable, so we're looking at that as a response to what the board has asked us to look at. As I mentioned, we've seen an issue where emergency room use is no lower in our HDHP plan, which was a surprise to all of us. We thought it would be much lower. The concern is that people are deferring care that would be more preventive and maybe more early stage and waiting till it's a crisis and going to the emergency room. That's not a good use of healthcare dollars, and that certainly would be something we would want to discourage. We continue to work at providing better educational materials, as I mentioned, to our members to help them make the decision before they're in the crisis, before they're sitting in the doctor's office trying to figure out if they really need a surgery, before they need to go to the emergency room. So that's a long-term project for us. We do have a couple staff that pretty much do nothing but work on communication for our members to help them understand their plan. We do have lots of permutations, so that's a hard thing for people. And then one of the other things that I think Justin touched on that I think had become a concern for us is long-term sustainability. The simple fact that we continue to raise the member cost share and it's not changing the cost curve, our concern continues to be whether or not we're going to eventually drive some of our lower wage workers out of the healthcare system. If you're a single mom, you're at the lower end of the wage scale, you have to pay your premium, you have to pay a lot of deductibles, you have a child that possibly needs some specialty meds, it becomes a concern to us that our program is affordable for that person, and that's something we are very carefully looking at. One of the nuggets that I see as a positive is the Trump administration rule that requires a more disclosure of healthcare costs, and we're going to watch that pretty carefully to see what kind of an impact that'll have.
Yeah, so. Great, and we'll come back to other kind of policy drivers of all of this in a couple of minutes. So, Michele, as we were having our kind of planning call for this panel, I was really struck by the frame that you and others used in terms of how we think about the problem we're trying to solve here, which is to really help individuals and their families find, understand, and access and really take advantage of the services that they need to support their health and healthcare. So it's this multi-step process, right? And you led us through that great exercise of, even in this room, we're all likely to get tripped up at any point along that continuum. So I wonder if I could ask you to also think from the perspective of, so if those are all the challenges, what are some of the things that are working? What is the growing field of health literacy teaching us about how we can take this complexity that everyone on the panel has talked about and that we've all lived through, and kind of drill it down to some strategies that actually can work to help people, whether it's pick the right health insurance plan or find the right care when they need it. So talk to us a little bit about what works and what you'd like to see more of.
Sure. I think one of the gold standards in design right now for information is co-creation, where you work with a team of perhaps health literacy experts. You work with a design team from the healthcare system, and then a group of community members, a broad, diverse group of community members that can co-create together the information that you plan to share with your members or consumers. And that's something that at Wisconsin Health Literacy we just started doing with a health insurance company. And I will say that at the beginning, the design team was pretty skeptical, and they thought this was going to be some kind of touchy-feely, we all like each other kind of exercise. And they walked out of that session, and we did it a couple different times. We brought community members in, various levels of literacy, representing various demographic groups, and they said it was one of the best things that they'd ever done. And they had learned so much from that in terms of how they were going to communicate information. So I think co-creation is one. Another thing is, field testing materials with, most every community has a local literacy agency where partnerships with community organizations that are serving populations that you're serving, being able to partner with them and at minimum field test materials for understanding. I think there are two of the things that come to mind right away that I think can really make a difference in how we're communicating that information. Access is really hard, and that, again, being in community, one of the things we're also trying to work on is in developing what we're calling community intelligence, much like emotional intelligence. You all know how that works, but for healthcare providers to really understand and be a part of the community intelligence of the neighborhood or community that they're serving, I think becomes really important. There are strategies to do that. And then there are lots of strategies in healthcare around plain language and talk back where patients can reiterate back what they learned from the provider in front of the provider so they know they go home with the right information. So a lot of different strategies for oral and written communication understanding.
Mm-hmm. Great, thanks. David, your research touches so many other parts of the broader system, so some healthcare directly, as you alluded to, but also mental health service delivery to the extent that that's a sort of specialty piece of healthcare, the WIC system, working with people who have had some contact with the Medicaid system. And I wonder what you're finding as far as what is working and what big gaps you still see in terms of helping the sponsors and program administrators of all of those various systems really understand the full lived experience of the people that they're working with. Is anybody doing this well in the work that you're doing, or do you mostly see room for improvement?
You want me to be honest, or you want me to
Yes, I do. These people want you to be honest.
I think we can do a much better job at the delivery of services, particularly for low-income families. And I'm speaking of low-income families who are making less than $12,000. I think their population is very invisible. And then when you particularly look at black males, they're invisible whether they're making $12,000 or $100,000. It's something I think many black men experience on a regular basis because of just as the society that we live in. One of the things, though, and there is some good stuff in what I've done, and I've been very happy with the work I've been doing over these last 20 plus years. And more recently, when we've been doing work around infant mortality, for example, we've been engaging men in conversations around how do we market information to that population more effectively, but also how do we make use of social media in a way that could possibly educate them on how, what is prenatal and postnatal issues they should be concerned about, and how can a father's role be more engaged. One of the things we learned in our 3 years, we've done 2 different studies. Myself and another occupational scientist have done some work, and what we found is that the men were much more engaged than we thought. Their biggest issue was that the nurses and physicians would totally ignore them when they came in the room. That was what we learned very much so. But then in our initial finding, when we did the study 2 years ago, in our more recent study last year, we found that doctors and nurses have improved for whatever reason in the Milwaukee County delivery of services around prenatal and postnatal care, which was very enlightening and also very positive that we were able to see that. The one thing, though, we still have a long way to go around recognizing men as family members. When we talk about family in America, we tend to think mother and children. We tend to think the children are owned only by the mother. And I'm not a father's rights person at all, but I know that there's men who are very engaged in their children's lives on a day-to-day basis. And I do think that we tend to not recognize the resources that men bring to these situations, particularly when they're unfortunately having employment challenges, when they could be the child caretaker, they can be the one that takes them to those doctor visits, they could be the one that goes to the school meetings, they can be in a variety of ways involved. But we need to really reframe how we look at family, and particularly looking at it through, when we look at it, think about how we look at it for race, by race in particular. Also, one thing that in that we were very much encouraged to now. Someone we're working with just got a major grant to develop an app. And so we're working with low-income men in the city of Milwaukee to develop an app that they can use, because everyone has a cell phone, and to use that app to talk about the first month, what the baby looks like and what's going on with the baby and what do you need to be doing. Unfortunately, infant mortality cuts across all socioeconomic strata for black women. Whether you're uneducated or whether you have a surgeon's MD and you're a surgeon. Black women have the highest rate of infant mortality. That's ridiculous. 3 or 4 times higher than anyone else. And it's unfortunate. So we're trying to also expand our work to not just look at low-income black families, but look at high income as well, which we're trying to get grants for right now. Another success that we are finding that in our work is that I did some work around looking at access to services for WIC, which is the Women, Infants, and Children's program, which provides food and other health care benefits for low-income families. And what we did was we got a wonderful WPP grant from Madison. We looked at, in Kenosha, whether men were coming in for services with the mothers of the children. And over a 6-month period, we were able to document, and they didn't even realize it, 600 men who were coming with the mothers of their children, and they didn't even realize it. And so through that, we were able to use that data to have now the state is paying for a fatherhood program there, because they didn't even recognize the value men were bringing into having the fathers there, acknowledging their presence, but also acknowledging the fact that they were a viable partner who was very engaged with their children and the mother of their children. So that's something we're very excited about, and I'm writing a paper up about that particular finding right now, because it's now been in existence for 5 years, and I'm looking at it over a 5-year period, and very excited about what we've seen and how you can engage men in a way that, even though it's called a Women's, Infant, and Children program, men were very engaged, and it's another way to help families as well as children be better off. The one around my Medicaid, the Medicaid one I brought up earlier, we still have a long way to go on that one, because it's an issue of finances, and right now you cannot charge the person who gets the benefit. That's a federal law, but you can charge the other person who is a partner, and the partner is generally in a heteronormative way is the man. So he's the one that can be charged for that particular benefit of birthing costs. I know the ABC for Health has been very actively engaged in trying to figure out how we can get rid of that particular charge, because it is causing many people to say, I'm not going to get benefits until the last minute, and it could be having some very significant childbirth outcomes. But again, and I did say earlier that Wisconsin's one of the most aggressive states. There is another state, I forgot, New York, and another state that uses it somewhat, but Wisconsin is the one that is the state that has been at the forefront of using this benefit in terms of recouping costs for Medicaid.
Right, great, thank you. So David brought up digital therapeutics and digital prompts around health behavior or other kinds of engagement with part of the health or the human services system. Justin and Eileen talked a little bit about on-site clinics, and those are two strategies that I have been reading about, and you'll all tell me more, that are starting to emerge as maybe the kind of next wave of strategies to engage people in their own health and their own healthcare decision-making. So I wonder if anyone on the panel would like to elaborate on, whether it is kind of on-site clinics or near-site clinics or digital therapeutics as ways to kind of grab a hold of people at a moment of need to help with that more sort of real-time engagement. Do you see promise in those strategies under our theme of better engagement of consumers? Do you see them as having limitations? How do we not make some of the same mistakes that we've made with other efforts around consumer engagement? What should we be thinking about there or kind of watching for?
I can speak. So, because we're looking at it, as I said in response to a question from the board, we went into it with a fair amount of skepticism, mostly because as you go back to where the population is concentrated, you also have a concentration of healthcare facilities. We continue to examine it, and there's a paper sitting in my inbox from a staff that I haven't read yet that talks a little bit more about where we go. I would tell you some of the reasons we're concerned: concentration of healthcare professionals, can we get them in the right place? The initial setup cost is something between $500,000 and $1 million, which is not inexpensive for you to reap some cost savings. The way the state employee pool, and I think this is probably unique to state employees, is there aren't really any incentives for them to go to an on-site clinic versus their current health insurer. In fact, there might be some reasons for them not to. And I think we have the sort of overreaching concern of state employees not wanting their coworkers and or their boss to see they're going into to get some medical care. So those are things we all have to overcome before we would go too far down that road. But
although in theory, that last point, that would be true of any worker in any workplace, right? So have we struggled with that other places?
Yes.
Or
I don't know. I think some of the research we've done has suggested that in a place where there's not multiple insurers, and that's an administrative issue we will also have to overcome, which is how do you bill the right insurer, or do you just figure out a way to pull it out of the standard health insurance contracts we offer and administer it that way? And it functions as kind of a first step on a work-related injury or a return to work. It might be a little bit more effective. So that's some of the things we're looking at in terms of how we manage the on-site clinic question.
other thoughts on that from anybody else on the panel? Anybody else want to jump in?
So I guess I'll add a little thing. So I think there's a lot of activity on this sort of digital front around health behaviors and a whole range of interesting things. So, you know, David gave us one example of prenatal, postnatal care. There's a lot of this for exercise or, you know, back pain issues that some of the local, you know, even the local HMOs here are doing some innovative things, trying to use the app systems that people have access to in data. And so I think there's a lot of promise on some of those ends. There's a lot of work to be done because I think, you know, getting meaningful engagement through those things and thinking carefully about what behavior are you trying to influence or change is hard. But there is a, you know, there's a broad ecosystem of people who have researched things around health policy change and so, health behavior change. And so I think, you know, there's some positives there. I think on the sort of digital side for more of the cost-based issues, you know, we're at much earlier days, I think, where the big issue is getting the data. And so, you know, Eileen mentioned sort of efforts towards data transparency and things. You know, I think a big piece of this is getting things organized in a way where within these systems we can tell what things are going to cost and why and where. And so I think we're probably further away from being able to make meaningful end user products in that space. But I think there's some interesting opportunities in the next couple of years around the more root level of just trying to understand what data do we have, what do we need access to, how do we get it, and how do we start sort of stripping out some of the complexity within the system.
Yeah, great. Michele,
I'll just add real briefly that we still live in a world where there's a digital divide, and that while most everybody has a cell phone, or most everyone is has a smartphone, how your your just pattern of behavior works in terms of your exposure to those kinds of things is very different. So again, I go back to designing of those types of apps and making sure that they're designed in a way in which people that might not have that much experience are so used to having their phone in their hand all the time and looking for things and using apps would be included in that design and output of those kind of efforts.
David mentioned some of the changes that you're starting to see for the good, it sounds like, in the provider community in Milwaukee. I'm reminded of an anecdote I heard from a physician who said patients are now walking in and asking providers, what app should I use to manage my fill in the blank, right? Mm-hmm. So to the point about not only do we need more work to be done on the front end in terms of designing those kinds of strategies in ways that all of us as mere mortals can actually use them, but now we also need to be preparing our care providers, maybe even our insurance, sponsors, et cetera, to really be advising patients on that aspect of consumer engagement. So in some sense, consumerism has sort of, taken off and taken hold, and to Justin's comment, some of us are kind of running to catch up with where that field is going. So Michele, just to stay with you for a second, so given that seems to be the case, what other kind of principles can you help us with from sort of that broader field of health literacy to not let this become just a runaway train with a lot of information that really is adding no value and changing no behavior for the good?
I'm going to go back to just involving the community that you serve in your design and that co-creation concept. Also, I feel like a commitment from top down to this kind of community intelligence about who your consumers and patients are and what they need, and truly understanding that. And that goes back, that connects to social determinants of health, and it connects to so many different things. So it seems a little bit overwhelming, but starting really with a top-down commitment to understanding and knowing the community you serve, I think is just it's a very broad strategy, but it's extremely important. And when that is there, I think then things, flow from that point where the community is involved and they have a say. And it is amazing what you learn from, we did a navigation study with a local hospital here and adult learners, and how they navigated just the emergency room to the prenatal care and birthing center of a local hospital, and the words and vocabulary that were suggested to us and to the hospital staff in terms of how they were going to get from here to there and navigation were so appropriate and enlightening, and it made so much sense. And it was something that never came to the mind of the healthcare design team, how they would say things. And so I don't want to beat a dead horse, but it really is, there are different ways to say that. It's so easy to get caught up in whatever industry or field we're in the jargon and how we feel we can do things. And I think also we prescribe a lot of what communities need, as opposed to asking the community, what is it really that will help you, or what is it really that you're going to do? Are you going to use that app on your phone? And maybe a lot of people don't think of it to use an app to find a parking space or a restaurant or whatever, but maybe your community doesn't consider those types of behaviors, and it wouldn't be that useful. So again, just asking and engaging.
One of the things I wonder about, and welcome feedback on this, I think in healthcare we're kind of uniquely challenged by the evidence base, right? So maybe one of the reasons we don't turn to the patient or the consumer and say, what do you think about this? How could we make this more meaningful for you? Is we're so busy trying to make sure that everybody's getting evidence-based care, right? And the minute we start to turn it over to real people, we sort of risk lack of fidelity to whatever that sort of evidence was telling us about what should happen in a particular situation. So how do we not get ourselves stuck in that, in that conundrum, right? How do we make sure people are getting evidence-based care in a way that they can understand and take full advantage of it? I don't think it has to be an either-or kind of situation. That's for Michele or for anybody on the panel if you have a perspective on that.
Yeah, I just think there's room for both, and there has to be both. If you don't approach it from both sides, you'll never truly serve the consumer or the customer that you're trying to serve. So I do think there's room for both.
I wanted to ask you, because you...
Push back. Feel free.
When you say evidence-based care, for whom?
Right. Great point. Great point. Where is the evidence coming from? What do we know about as we
And who
move
was the population that they tested to get this evidence?
So say more about that. Say more about that. Why should we be skeptical?
Only because I think, in Milwaukee, so many of the men that I've talked to in families are using the emergency room as their way of getting health care because they don't have the funds. We do have I think Badger Care is a great program. I've always thought that. But we don't have a enhanced, I can't think, I should know the word because I teach policy, right?
Expansion?
Medicaid expansion,
Right.
thank you. I couldn't think of it. We don't have Medicaid expansion. And of course, my immediate thoughts when I hear that is that the population that's going to suffer are single adults, men and women, who need the access to that care. And if they don't have children, again, that tends to be the way that we frame everything. If you have children, you're going to get that benefit, which is great. I definitely think that should happen. But again, the group that consistently is losing are those who are without children or these non-custodial fathers that I've done a lot of work on as well. And I mean, there's still evidence out there around the fact that black people are discriminated by doctors 32% or more. I mean, I just heard an NPR study about NPR story last week about that. There's many studies that say that black people can tolerate more pain, so the doctors are less likely to give them medicine. There's many studies that show that black and brown people are not getting access to care, particularly in Milwaukee, where we have a healthcare quality and access issue. We have discriminatory incarceration, and we have residential segregation, and we have food deserts. People are not going to be healthy based on just that alone that I see every day when I'm doing research in the community. And so I wonder, when we hear evidence, with that evidence, you're expecting your client who's coming to get service to present in a certain way that may not be the typical person you're expecting to serve. They may not look like that person that you expect them to be. They may not smell like that person you expect them to be. So then you treat them differently. So for me, it's a big issue of we as a society have to decide if we want all of us to be better, we need to treat everybody the same and provide everybody equal access to services. So when I hear evidence-based, which I get it as an academic, it makes me want, who are they basing this evidence-based work on, and who is the population they're talking to? I know we can oversample and all those other things to be sure that our data is all qualitatively sound and scientifically proven, but the voice of those who are black and brown is silent on many of these issues. Right. And it makes me very concerned when I hear evidence-based practice, but again, there's other discriminatory practices, as I've learned from my other economists that I've talked to a lot, who are doing this whole idea of stratification economics, where you look at how does discrimination play into the delivery of everything that's out there, from employment to healthcare to whatever it is. So anyway, I didn't mean to go on a rant.
Yeah, no, you're absolutely right. You're absolutely right.
And I just want to add, last week the Wisconsin Health News put out the article that Milwaukee adopted this ordinance to look at committing the county to advancing racial equity, and that, we are 2020, and in Milwaukee County, a white person has an average lifespan 14 years longer than a black or brown person in 2020. I mean, and that the infant mortality is, as you mentioned before, David, 3 times more likely for a black mother to lose her baby than a white person. And I think about that's evidence-based research that is telling us this, and the community is telling us this, and connecting both of that evidence base and what is actually happening in our communities that we don't know about, or we're designing policies without really paying attention to that, is where, I think has led us to this position where, we spend a lot on healthcare, and we have some of the most, horrible outcomes, particularly for people of color in our country.
So that's maybe a good opportunity to then start to pivot from we've had this focus on the consumer, right, as the agent of change. And I think what this discussion is really lifting up is there are limits to the consumer's ability to really affect change, given all the other constraints that you all are talking about. So let's just take a minute and think healthcare still with me for just a second, but let's look around the rest of the stakeholder table and let's talk a bit about what some of those other actors could be doing differently and better to try to, again, more fully engage consumers in their own health and healthcare. So let's talk about insurance carriers and insurance plan sponsors for a second. So as we start to think about strategies around better consumer engagement, what is it that insurers and plan sponsors maybe are doing well? What is it that they could be doing differently and better to help with real consumer engagement? Anybody want to tackle that one?
Well, I'll start a little. So as one example, a group that I was working with, we got a small pilot grant from the UW to try to look at improving communications about where to best access care for a group of people in a health system that was being largely served by Badger Care. And so we worked with UW Milwaukee Extension to sort of hold focus groups with community members to try to think about how do you communicate well. A number of pieces around health literacy, trying to sort of think about how do you communicate these things well, and design some new flyers to sort of try to share with people, okay, here's where to go for care, and here's some simple things like here's a magnet to put on the fridge with the best telephone number to call if somebody in your house is sick, and sort of where to ask. And the interesting thing engaging with the health partner who was working with us on this work was just that they have a lot of information that they try to share with people, and there's a lot that they're doing, but they're pretty far away from meeting people well where they are. And I think part of that's community engagement. I think part of it, though, is also that just within many of these complex systems we have, these big healthcare providers, health insurers, health systems, the people whose job it is to do that sort of communication are often not at the sort of forefront of support and sort of seen as, really central to the mission of what's going on. You also see this when you talk to large employers and you think about what's going on with health benefits. Some of the most important people in those organizations are the people who design the forms and the way that you access your healthcare benefits, and yet they rarely get a ton of support. They're rarely the most highly paid employees. They're rarely sort of given awards for like form design of the year. But in many ways, sort of simplifying those processes and trying to meet people where they are is a huge sort of low-hanging fruit, I think, at a lot of these organizations. So I think, to the extent that we have organizations in the room that are interested in these issues, getting down to sort of the nitty-gritty details of how we're communicating, how we're designing access and information flows, and working with, people who have genuinely studied questions around health literacy generally, and sort of know how to get engagement from the community members who are going to be affected. I think there's a lot of opportunities there.
Right. Other thoughts on that? What insurers could either are doing well in this space or could be doing a better job of?
A couple things from our perspective. We just finished a series of meetings with all of our participating insurers. We have 2 left to go. And we were looking for ways where we could partner to look at specific cost areas, to see if there's anything we could do. Being as big a purchaser as we are, we have a tendency to set our prices, which means we kind of have an obligation to help them keep the cost down. So we're looking at a bunch of strategies related to emergency room use, for example, that don't involve raising the member cost sharing, but are there other ways we can help people better use healthcare services? And it's everything from, if you're an employer at one of our state institutions and you have somebody who calls in sick, do you have a policy that requires the person to get a letter from the doctor, which the only place they can get that is the emergency room? Again, not a good use of an emergency room. Is there a better way we could do that? Can we help our members understand what telehealth we have? Because we do have telehealth in all of our plans, and the utilization is very low. So we would love to encourage more usage of that as maybe a way to get a better handle on costs.
Okay.
So a couple things that strategies we're working on. So.
Super. Other thoughts on that one?
I just, I don't know if I have the strategies, but the transparency is such an issue. And when people can't make decisions about care that they need because they really don't know what it costs when they go in there. I mean, just there are just so many. I have an example of looking to find cost, navigating that for my husband had a recent bypass surgery, and I wanted a second opinion, and I was denied that, so I went to the surgeon for the second opinion to their office to find out, well, if I'm going to pay all this out of my pocket, what does it really cost? And she referred me to another person in finance who had to refer me to another person in coding who gave me 5 different price ranges of what this consult for a second opinion would cost, ranging from $250 to $950, depending on the severity of the procedure. Yeah. And so when we got to the visit for the consult, they said, well, if you pay up front, we'll give you a 40% discount. And so my card got charged $300. And I still to this day do not know if that's the end of it, if I'm going to get billed for more because it was a quadruple bypass, so I thought it was going to be on the higher end. I mean, that's transparency about what did I really pay. And I am someone that is fortunate enough to have the education, the background, and the socioeconomic status that I'm okay that they charge my card $300, but there's not a lot of people, everyone can't do that. Right. And so this was a procedure that, was very serious and life-changing, and yet I was denied my second opinion, but was able to pay for it out of my own pocket. But we deny a lot of people that access and cost. Yeah. Without cost transparency, you can't make decisions.
I'm really glad you brought cost transparency back up. Eileen touched on it a bit a couple of minutes ago. Let's just stop on that for a second before we keep going around the stakeholder table. So, right, I mean, great example of what it actually looks like today to try to have transparent healthcare cost information. So now, as Eileen mentioned, we've got some public policy efforts to try to put at least price information out there in the public domain, which this whole room knows is not the same thing as cost, is not the same thing as consumer share of those costs. So what do we do about this? How do we start to shape cost transparency in a way that's actually going to work for people with their varied levels of health literacy and numeracy and available time and all the rest of it? Is anybody doing this well anywhere in the state, in the country?
Is there an app for that?
I'm sure there are 27 apps for it, but will any of them work?
So I don't have a good example of somebody who's doing it really well, but I'll give you sort of my perspective on maybe where the starting point's likely to be. I think it's going to take a while, and it may not be the best use of resources to try to do a really good job of getting to this point where people can figure out exactly what something's going to cost before they make their decision. I think it's a high priority, but the system is currently so complex that it's going to be really hard. There's a lot of systemic change that needs to happen before systems can do that. But the piece we can do now actually is making a little bit more transparency ahead of time of what are the experiences with out-of-pocket spending under different health plans and with different healthcare providers that people experience. So at the end of each year, these big health systems, increasingly the ETF and a whole bunch of other people have access to exactly what people were billed and what the flow of those bills were like. So, we could potentially within, not too long, give people things at the moment in time that say, okay, if you're in for instance, the ETF plan and you sign up with this plan versus this plan, here's been the history of spending and charges that people get exposed to. So I think there's a range of ways that we can at least start putting some consciousness and some pressure in there that then may feed down the line into this more at the moment of service. I think, solving Michele's problem is a really important one, but hard. But the other one I think we can start doing now-ish. Mm-hmm.
And the other thing I would say is I think we need to continue to be focused on patient outcomes is really the bottom line. It doesn't, there's no correlation, we all know, between the cost and what's charged to the person and what their health outcome is. So we need to get everybody focused on what health outcomes there are and how any steps that anybody is taking to do this makes members understand this doctor had these kinds of health outcomes, these kinds of complications. That's, I think, one way we can, and get away from the value conversation, which I think people are frustrated and bored with, but help them understand what if the doctor they're seeing has good or bad outcomes related to the overall condition. And again, it's going to drift into some really technical stuff because there's always going to be risk adjustment, but and that's a hard one, and that's always what everybody relies on, but we need to help our consumers understand that Dr. X has done this many of this procedure and he's had these many outcomes, or she, and maybe is the better proposition for you as a member.
Right. So that's a good transition back to our stakeholder table. I want to talk providers and then policymakers, and then we're going to open it up for questions. So be thinking about your questions, and I'll just say in advance, great wide-ranging discussion. Try to help us understand who you'd like to respond, at least first, to your question as you're thinking about it. So providers are all preparing for consumerism, right? Lots of discussion about the world of the future of healthcare is this rise of consumerism, and therefore we have to be prepared as a provider. And I wonder what you all would like providers to be focusing on in terms of, again, helpful and meaningful consumer engagement. Not just the rise of consumerism, not just the rise of apps, not just, some of the other things we've been talking about. And maybe it is what Eileen said about, best care, best outcomes, most cost effective, most culturally and linguistically responsive, best hours, best locations.
Yeah.
Right? I mean, is that the list?
I think that in healthcare you hear a lot about the quadruple aims, better provider experience, patient experience, better health outcomes, and lower costs. But you don't hear a lot about what are the consumer quadruple aims. And I think talking about consumer quadruple aims, which would be the right care at the right time for the right price and in the right place. And if providers were talking about that, as much as we're hearing about the quadruple aims in healthcare, I think that would be a start.
Other thoughts, other advice for the provider community? Otherwise, we'll shift to policymakers. So it's Public Policy Forum. We have to talk about policymakers. So what's the role for public policy, either at the federal level or the state or even local level in promoting what Michele just articulated as the consumer quadruple aim? How can policymakers help? How are they making it worse?
So I would tell you our board just adopted the triple aim, not the quadruple aim, as sort of the guiding principle that they're going to apply to policy decisions and discussions we bring to them. We want them to think about cost, quality, member outcome, member experience, the whole deal. So that has become sort of our guiding principle with our current board.
And great point that government purchasing of healthcare is itself public policy, right? I mean, you're not
Especially
passing
when you
anything,
have as
but
big
you're
a foot in the room as we do. So,
for sure. Other thoughts in the public policy arena?
I just want to speak on the government-sponsored insurance, Medicaid and Medicare. For Medicaid, stop birthing costs being charged to non-custodial parents. It's further encouraging social determinants of health in the way that people are stressed out they can't pay the bill. They are stressed out because they're not sure they're getting good care. They're stressed out because now they could possibly have a loss of a driver's license or a lien on their property or a loss of some other type of economic means that reduces their economic security. So that's one thing that I think needs to happen. And also an examination or clarity in looking at the provision of services when people are Medicaid and Medicare sponsored physicians or nurses, that those practitioners provide quality care and don't just see it as an opportunity to make money off the backs of poor people. Whoever they are in rural and urban communities, it happens. And I think that needs to be more clarified and thought of. But I do think government-sponsored insurance needs to be looked at clearly, but this whole idea of charging people for an entitlement that they thought they were going to receive causes all kinds of concerns for both parents, mother and father, particularly when they weren't aware that they were going to be paying it back, whether they're married or not married.
Talk about transparency, right? Yeah,
yes.
Exactly. Thank you. Okay, so Michele, last word.
Just
and then
one
we're
other
gonna
thing
open it
I
up for
think
questions.
government can do is regulate reading levels of, for instance, health insurance policies, where, if we look at that in terms of bringing it from above a 12th grade reading level down to around an 8th grade reading level, preferably lower than that, to really understand what your health insurance does for you, I think that would be a start that government could regulate.
Great, thank you. Okay, we're going to open it up for questions. So if you could raise your hand so Victor with the microphone can find you. If you could let us know your name and please address your question to one of our panelists. That would be fantastic.
Thank you. I'm Barbara Nichols, a registered nurse and the executive director of the Wisconsin Center for Nursing. And my question is for the total panel. Before I ask the question, I have a one-sentence prelude. This is a whining statement. I'm appalled and shocked that nurses, which are the largest providers of care in the state, in all healthcare settings, I don't see anywhere on this panel or in this conference. They are the ones who interact directly with not only communities of color, but patients in all settings. So my question to the panel and to the Follette Forum, how do you involve registered nurses in your policy formulation? Because what I deduce from this meeting, you don't think that nurses have anything to say or can be assistive in public policy formulation. So that's my whining statement.
Thank you, Barbara, for bringing us back to what's important. Thoughts about the role of nurses and nursing in the consumer engagement, health literacy conversation?
Well, nurses are very involved in my work, and that didn't come across through the WIC work I've done, the infant mortality work I've done, as well as my Medicaid issue. I learned all that information from nurses. All of my programs have been working with nurses in the WIC centers in terms of how they were the ones collecting the data for me when I wasn't there on how many men came into the program and how they observed the father's role in the lives of their children in that particular. And so then with my infant mortality work, I'm also learning from nurses, and I'm working with nurses on my project there. So I engage nurses all the time. If that wasn't clear, when I said, and also my men have talked to me about how nurses are more engaged in talking to them about their involvement when they go into the prenatal and postnatal visits. So,
The point I'm making.
yeah.
They're doing the work, they're there with the observations, but they're not referenced as a critical variable in the determination, for example, of their very informative outcome.
Yeah,
Well, I'm sorry I didn't say it sooner, and I really like nurses. They're great people.
Thank you, Barbara. All right, more hands. I saw Tim, and then who can we have in the queue after Tim? Over here.
Thank you. This has been a very interesting listen. My problem is, and you have to do this, I think countervailing power is really important. Ellen, right? Ellen, is it Eileen? Eileen.
Yep.
We have a duopoly. We have UW Health, and we've got Aurora, and they're buying up all the rest of the state. We do not have competition. They're going to do what they want to do, unless you put pressure on them about, for instance, one of the topics that was, was talking about is balanced billing or out-of-network billing. I want the records on who's doing that to whom, because it's happened to me. Justin had exactly the other idea as well. What's the level of satisfaction with care? How does consumer pressure can be put on? If we're going to have choice, and we don't have competition, we need the power of the purse to really get on our major providers. You can't go anywhere in Wisconsin without seeing a doc in a box from UW Health in any small town. And I mean, they're billing Quartz, which I'm insured with, of course, is a billing agent for UW Health. Full stop. Okay? So I'm worried about the other side of the market and when the consumers have to exercise some power. So I'd be interested in what Ellen has to say, and Justin.
Eileen, yeah. So how do we empower consumers in an increasingly consolidated healthcare market?
Well, I can tell you it's one of the things I lose sleep over is consolidation in the industry. And it's not just the fact that we have a shrinking number of insurers, but there's been vertical integration across the entire healthcare system. As a purchaser, which is what we are, we can tell our insurers, no, we're not willing to pay as much as you want us to pay, and that's the tact we've taken. We continue to try to have at least 2 HMO carriers in every county in the state. I can tell you, in 2019, when we had one, Quartz, raise the local rates significantly, and another one, Dean, came in with significantly lower rates, we saw a huge migration of people. They voted with their feet. They moved from Quartz to Dean. And we are not going to back off on our no, you're not. There's nothing that justifies. We have actuaries that help us set rates every year. So we're not going to back off of our approach of using actuarially determined rates and actuarially justified rate increases. But like I said, I do lose sleep over this. My staff has all heard me rant about integration and the concerns that we have. We continue to be lucky in that we don't have the larger carriers as part of the state health insurance program. They're the local insurers, and the good news is we can have a face-to-face conversation with them about costs. I'm not going to tell you that it's 100% successful, but it certainly is an area of conversation we often have with them.
Thanks, Eileen. Other thoughts on that? Other thoughts on that sort of individual consumer versus big institutional actor? Clearly a key dynamic.
I mean, I think it's one of those interesting places where, there's a role for high-level policy. So, enforcement of antitrust policy and thinking carefully about, what is the market power and how's it growing is an important policy lever that we need to have conversations about. I think the purchasers of insurers, which are often the employers, but, sometimes also our state agencies, have a role to play in putting that pressure on in as best way they can. We've already talked about some of transparency, but I think also, devising systems that help give people the ability to, I think as Eileen said, vote with their feet when they can in a way where they can feel comfortable about that. I think, one of the ways in which large systems sometimes have their power is that we're all a little bit nervous about whether we're going to need access to the very best doctors in the worst case scenario, especially for our kids and for others, and sort of being able to have a sense of, okay, exactly what can I get access to where, and where can I push back on costs and where can't I, is a multifaceted thing, as Eileen was saying, that we need to help people understand both what's it going to cost in different things, but also who's providing quality care, and how do we measure that and how do we convey that to people. And so, I think there's probably a role here from everything from very high level economic policy all the way down to sort of designing systems that let people make some decisions and vote with their feet.
Thank you. Next question, right here, and then can I have somebody in the queue behind this? Okay, Haley in the back there, and then coming back to you in the front row.
Hi, my name is Ron Stanoff. I'm currently a student at Follette. Quick question for David and Michele. You guys talked about health literacy, the racial inequalities that exist in our healthcare system. And in classes, I hear the buzzwords of health and all policy, social determinants of health. And when I see your guys' topics, I see it, we see it in the healthcare system, but it's kind of a larger societal problem. And to what extent can we hold the healthcare industry accountable to these problems without acknowledging that they exist beyond much more, like larger than just healthcare in that extent and within your own work?
Well, what I've tried to do when I do talks around this whole issue of social determinants of health is say that it's much bigger than one system. You can't say that healthcare is to blame for all the issues that people are facing. They may contribute to it, but they're not the only system that contributes to why we have poverty or lack of access or incarceration or divorce or many of the other things that people talk about around the social determinants. I think that though with healthcare, which is one of the major issues that people need to have access to, they could have quality healthcare. They may not be able to, and they need to be able to, and it needs to be affordable. And we, as a industrialized country, as one of the few industrialized countries in the world that doesn't have access to healthcare, just as a guarantee of being a citizen of this country. I think that's a big issue that's bigger than healthcare is is an issue around how do we look at the worthy versus the unworthy in this country? How do we look at those who are deserving versus undeserving? How do we look at race? Let's just go there. And how do we look at gender? Let's just go there. How do we look at class? All three of those are just very important in this discussion that I think we all are nervous to have that discussion. It makes us very uncomfortable. And I'm not a person who wants to give you, here's what we can do to make it all better. I want to do truth and reconciliation at this point in my life. And if people don't want to know the truth, then I have to keep moving on and keep telling that to someone who's going to listen. That's why I think in a conference like this is really important. And talking about what contributing factors what does health care do to contribute to the factor that people are impoverished. And it's something as simple as a Medicaid policy where someone is charged a birthing costs and they didn't know it, and it could be anywhere from $1,200 to $70,000 or $80,000, depending on your child. They're contributing to it by not giving people information about what they're getting into when they sign a form that's for a variety of reasons. I don't want to go into a long rant, but if you want to talk to me afterwards, I'm happy to come to your class and do a lecture.
There you go. Nice. Michelle,
just briefly, I mean, there's policies, practices, and power structures that have been in place since our country was founded and that are still in place. And, they are primarily benefit white people and disadvantage people of color. And those practices, policies, and that's what Milwaukee ordinance is about, is looking at these kind of systemic structures that are in place and how do we start to address those, because it's not just healthcare, it's workforce, it's quality of life, it's housing. It unfortunately, it's not just healthcare.
Thank you. Haley, and then front row here for the next question.
Hi, my name is Haley Chesnick. I'm with United Way of Dane County, and my question is for David. It sort of piggybacks after the last question. You had acknowledged racism as a public health crisis, and just recognizing that Wisconsin is one of the worst states in the country for racial disparities, like infant mortality, like you'd mentioned. I'm just wondering if you can explain a little bit more about what policy or even programmatic solutions you see that can help build cultural competency in healthcare delivery specifically to get at some of the root causes of those structural inequities.
Oh, you want a dissertation? Oh, that's a lot. I mean, again, if I had the answer, I would say it. I mean, I think one of the simple answers is that we need to recognize that, and this is an issue like with funding. I'm trying to get funding to look at infant mortality across socioeconomic levels. We only look at low-income families. It's affecting black women who have a surgeon's degree and they have a law degree. We lost 3 babies, my wife and I, during our time due to issues of stress. My wife's a lawyer. So I know how it affects people, personally and professionally. And I think that we need to broaden our discussion. We need to look at how does race impact everything in this country. And if we don't do that, we're not going to solve infant mortality or poverty or healthcare access or food deserts. We have to have a real discussion on race. And I definitely applaud even our president we have right now about that. This is a perfect time to have a discussion on race and gender and class. It's very clear that they want us to have that discussion in some kind of way. And you can direct that in ways that will allow us to make it better for those who are having those challenges around economic security. And also we're looking at what is this racial wealth gap historically? Why do we have such a significant racial wealth gap? Why did not men who were returning from service in 1935 or 33, whenever, I think it's in the 30s for sure, why weren't they given the same opportunity to purchase a home and develop some wealth for their families, and therefore not have and it's so clear that's one of the indicators of why we have such a significant racial wealth gap. So I think for reducing infant mortality, it's us having a willingness to have a real conversation about why is there such a difference and what is the role that racism plays in this country for black and brown and white families as well.
Okay, great. Thank you. All right, front row. And maybe time for one more question, so can I have one more in the queue?
Actually, you all addressed the questions that I was getting ready to say, especially Dr. Pate. I was just going to say, when you were talking earlier, I'm sorry, my name is Theola Carter. I'm with the Dane County Office of Equity and Inclusion, and I'm also a Follette graduate. So, had to get that in there. I was going to say, when you were talking about that particular plan, how many people did not go at the expense of their health and what they would have to pay. So they were sitting there thinking that's to Mr. Justin up there. And then I was thinking Dr. Pate said exactly everything I was getting ready to say. The federal government played a big part in a lot of the wealth disparities and health disparities and things that we're seeing, and they were not owning up to the housing issue, the racial issues, and the education issue, and all these sort of things. All these systems are overlapping with one another, and which is why we're getting some of the issues that we're having. And I was going to say the advantage within the system is not having your people be dumb. I'm sorry, if you're dumb, you don't know, the system has the advantage. So let's be perfectly honest about that, and having all the information available would not necessarily be in their best interest. So let's talk about that. As far as Miss Eileen, I worked for the state through 28 years. I'm gonna tell you, that stuff was so dense, I was like, group health, move on. And I'm just gonna say, it's so dense. And so you're right, there's a need for education and when it comes to it, but I was like, I'm not changing. Every October, I was like, group health, move on. So, and I wasn't gonna question the issue and keep on going in that regards. And when you were talking about the sampling, I was like, who did you contact? Because I would guarantee the people of color that I know would never say that they got a copy of a sample of cultural competence things so that you can give them some information. And it's like going to Wisconsin and they say, oh, Wisconsin, Madison is a great place to live. And it's great. And I think to myself, who did you talk to? So those are the things I just would like to say, although they're not a question, they're just comments.
Thank you very much. All right, last question. Betsy Abramson in the third row there.
Hi. Big segue from where we've been the last couple of questions, I guess. I'm Betsy Abramson with the Wisconsin Institute for Healthy Aging. And, you know, we use the word healthcare a lot, but we're really talking for the most part about sick care. And I'm wondering how we can move to more of a culture of well care and prevention, and how payers can influence consumer engagement there as well. And some of the consolidation you were talking about, Eileen, I kind of like some of these systems where the insurance company and the healthcare providers are connected also, because I see bigger incentives there for them to keep us well rather than waiting for the sick care to happen. So how can we get both systems and consumers engaged more upstream rather than waiting for the downstream? And I guess my questions are more for Justin, the economist, and Eileen, one of the payers. Thank you.
Well, I'll give a few thoughts. I don't have an answer for how to really move that, but part of the thing I think we have learned is that thinking in terms of really big incentives, like so for instance, some health system or insurance system setting up money that's going to give you some money for leading a healthy lifestyle or something like that. I don't think there's a lot of promise in those sort of things. I think most of us can think about it from our own personal experience pretty easily, that if we think about root health behaviors, they're rooted much more in our environment, our cultures, our traditions, and sort of we all have as many incentives as we need in terms of just how we feel and wanting to live long and see our kids and wanting to look good like all the models on TV and things. So the incentives are already there. So, and I think a lot of the effort so far has been a little bit misplaced in thinking about this as a sort of simple money problem that often happens. So I think, trying to think about ways in which health systems, where are they actually involved with people and where can they really make a difference? And so I think for many of our root behavioral things, like how we eat and things, they probably have limited ways of getting involved in our lives early, but if they focus more on the places where they can help. So new parents, helping them establish what are healthy habits for a lifetime going to look like for your kids, or you're starting to show some signs that you may develop a chronic disease, you're not there yet. How do we help people and intervene in the most effective way? So I think I agree with you that there are some investments, but I also think trying to think really carefully about where are the places that they touch people with behaviors they can change at a time when people can change them is going to be important. There's a lot of sort of just throwing money at an idea of people living healthier that I think doesn't go very far.
Right. And I would tell you from our perspective, when we actually sort where the state is paying money, the single largest thing that we have that's in terms of a diagnosis code or procedure code is preventive care, which to us is great, but that also means that the roughly 10% of our population that generates the most of our cost is probably not engaged in that, and we need to, I think, from a payer, get a handle on people with chronic conditions, getting them to the best place they can be. I think that's a higher focus right now, even though we have a very strong wellness program that does create incentives for people to go through several different, there's 3 steps they have to do right now to qualify for the incentive that they get. We have a really, really good wellness coordinator who is out there and is as enthusiastic about it as you can be and can get everybody enthused on it. I think for us, where we're looking at where the money is going out the door, the focus is probably more now getting people who are in a chronic or some kind of an advanced disease state into the best place they can go, so.
All right, much more to say, but we got to leave it there. Please join me in thanking our fantastic panel. Great job. Great. Thank you all. Thanks for being here. Enjoy the rest of your day.